broadly defined to really say great or not so great. And then I think that person's under guest and I don't know her. So who is that? Who made those points?
There were two of us. I don't know why I'm under guest, but this is Leslie Gordon from Food Bank for New York City.
Great. And then Sharon, who else made that same point? I forget.
Sharon Duke from Alliance for Positive Change. What I basically said was that there needs to be a reimbursement mechanism for the delivery of social determinants of health assessment and service provision. And until we know that there is a reimbursement attached to the delivery of those services, raising funds for a network of organizations that have no reimbursement mechanism is the cart before the horse, in my personal view.
Okay, excellent points. Good morning, Sharon. Hi, Leslie. Do we have a note taker? Relitza, are you taking notes? Okay, terrific. Okay, are there other reactions or reflections people have on key action number one? And can you all see the key? Yes, everybody can see the key action. Okay, great.
Yeah, this is Josine. The discussion around finding funding, because we're such a diverse group of organizations addressing the various needs around social determinants of health, I think we really need to understand what a reimbursement structure would even look like. Typically for organizations that are not within the reimbursable stream, under Medicaid specifically, I think those are some key factors. And how do we come together around, and let me also say, there is duplication of services within our network, as we all know. So I'm not sure all of what I'm saying, except for there are more questions and then I'm actually providing any really substantive comments, except for to say the fragmentation, the duplication, and the lack of standardized reimbursement streams currently within the network of community-based organizations. That's probably what I would say.
Yeah, I think excellent points. The duplication in particular, a lot of times I think we have duplication when we don't want to have duplication, and that's because we don't have visibility as to which CBOs are doing what and for whom and where, even when we're all grantees of the same project. I mean, ARNYC is experiencing that right now as part of the Public Health Corps. It was difficult to even find out within one sort of UHF neighborhood where we were funded to work in the Bronx, which other CBOs were handling which parts of the work. So I think those are excellent points. I do have some questions here, a moderator's guide that can help us maybe break these questions down into smaller bites. The first one for the key action one is, what do you see as your sector's role in financing a community resource network? For CBOs, we're not quite financiers of the network, but maybe we interpret the question in terms of how do we contribute our financial resources respectively? I'm not even sure if we should treat that question. Maybe we just skip it. Let's skip it. We don't have money. Question number two, what sources of funding would support both startup and ongoing costs of a citywide community resource network that your sector is uniquely qualified to tap into? Okay, I think that's also not so much for us. And the third one as well, also about funding. So if it's okay, Relitza, we'll move to key action number two, because I think that's where we've got more to say.
And I think, Shoshana, now
yes.
that I'm a participant instead of trying to replace you, I mean, I think Dosine's point about the difference between people who have a reliable funding stream because they're Medicaid covered benefit versus people who rely on external funding is really important, because getting a lot more referrals if you have no ability to take on those cases is not helpful.
Right.
Or having such intense eligibility screening up front, so that you have to know someone's insurance, you have to know their zip code, you have to know their ethnicity before you can make a referral. That's very difficult too. So I just wanted to amplify that for the record, because Dozine made that point. And what I find on some of these existing networks is the people who are on the networks are the people who need a lot of referrals because they don't have enough business. They're not necessarily the best service providers. That would be a really good accountable network.
I think that's an excellent point. The technology is necessary but not sufficient, and doesn't solve the problem of the underlying capacity and resources of the CBOs to deliver.
And also it seems, oh, I don't know where this thing went. Okay. It also seems to me that establishing a resource network, you first need to do your asset mapping as to what already exists and what organizations target or provide services to a particular target population. There are organizations, as we know, that crosses the age spectrum, while there are others that do not. So I think it's important to establish that network of who exists.
Mm-hmm. Mm-hmm.
And this is Faven from the Arthur Ashe Institute, and maybe along that, and to echo Leslie's comments, I think maybe I'm having a hard time thinking about how to answer these questions, because I don't have clarity on, have we defined what a CRN is? Have we defined kind of what our shared vision and mission is? Have we defined how we are going to be operationalized? Are we, I feel like there's, maybe I missed something, but I feel like there's quite a bit of questions about the CRN and who we are and what we do and how we're going to operate collectively, for me to answer more specific questions about funding and things like that.
And I can speak to that a little bit. I think, the question of what is the CRN is something we've essentially been asking in this symposium series. And so I don't know if you've been able to attend the other sessions, but so that's kind of like a theme we've been building up to. And I think something we've recognized, which I think someone already mentioned, is that there are a lot more questions than answers, but we have a few kind of key ideas that seem to kind of resonate with a good majority of people and a kind of cross stakeholders. So the goal of this session, in splitting it up by sectors, is to think really feasibly about what can we actually bring, like each sector, and what is the capacity to affecting kind of each of these key items. So, for example, obviously there's a very different conversation happening in the managed care organization group right now around financing, as is in the hospital and healthcare. And so I think, again, that pertains a little bit more to them. And so this question maybe relates a little bit more to, what are those needs and capacity building that have, kind of already been raised. But the CRN, like I said, has been kind of built up through the past few symposium sessions.
Thanks, Ralitza. I actually think that key action, Faven, good questions. Again, on the cart before the horse point that Sharon was making earlier, from a different angle. I think question 2, in fact, starts to get more into like the CBO lens on the topic. So if you could advance to key action number 2, Ralitza. So here, this is about creating an administrative backbone and infrastructure to support and facilitate the work of CBOs at all levels of capacity. So just reflecting on this question, we have a question for the group that says, what do you view as your sector's role, if any, in building CBO capacity? What would you do if you could? And what would you prefer to be handled by a network administrator? So that's our first question. And I think here, maybe we could think about ourselves as individual CBOs and also as the collective, as much as that's possible. Are there functions that we would prefer to outsource and have handled by a network administrator? And are there, of course, functions, services, programs that need to be directed, operated, from our respective organizational platforms? Anyone have thoughts on that? I'm sure we do. I'll start just to kind of keep it going. I know Jonah Gensler pretty well, and I know he probably has lots of things he'd like to say. But I mean, I think there are certainly core functions and competencies that we all need, but that are expensive, and that it would be great to have centralized capacity from which we could all draw. And when I think of what that would be, it would be like legal, if that would be, a way, if there was a way to do that without sort of, getting around conflicts and everything, or possibly around hiring, a centralized pool for talent, like recruiting talent that we could all go to. Somebody could help, that those could all be sort of like an MSO, a managed service capacity. Perhaps there are aspects of HR, other aspects of HR, and administrative aspects that we could, pool our resources, and then each of us wouldn't have to have those services on board that are expensive. Those are a few thoughts, but opening floor.
Shoshana, so I would respond that it's often very frustrating that every single organization has to get their own lawyer and understand, or their own tech people to understand new systems, when the requirements are really, 90% of it should be the same. And so, yes, technology, legal, HIPAA, those things should be centralized.
I agree. I think that's where many CBOs, we lack that expertise, or we rely on pro bono assistance, and that the cost to maintain those really important components as the infrastructure of our organizations is very important. I do think I would add a training component to that as well. I think that would be extremely important. And I would also add technology. Each of our organizations operate differently in terms of what platforms we use. But I do think having some type of technology resource and research are some key areas that I think could be formed under an MSO kind of model.
Echoing the technology, the pricing of technology is well beyond what most of us are able to afford. And at least we have found that through philanthropy or other contracted partners, we aren't really able to raise that money. And nobody really wants to pay for those tech platforms. And then the other issue with the technology that's not just finance is the standardization issue, right? Like the interoperability challenges that we all have, sharing data for, or mapping data because we're all using different things. So I think tech. And then what about what we want to retain in terms of our, our respective organizations, capabilities that if we have a minute, we can differentiate and say these things need to be decentralized.
I think that the unique relationships that are built need to continue and grow. And sometimes those relationships may be a few social workers with a hospital, and those have value. So if you centralize everything and there's only one conduit to the medical field, something can be lost there.
Anyone else? I mean, I know we're all sort of, we recognize that our work is very local. There are probably other aspects of our work that we believe we are the best sort of decision makers, and should retain authority to continue and to work independently. Do we want to name any of the other functions, or are they just too obvious to even discuss?
I want to just, in terms of the local nature of many of our CBOs, I think looking at a CRN on a regional basis, as far as to Jonah's point about, or I think it was Jonah's point about establishing relationships. Social workers have relationships throughout their network to help the client. I think by keeping the network on a geographical design would be very helpful also.
Shoshana. Oh, go ahead, Dorella.
Okay.
Go ahead, Dorella. Sorry.
Thank you. I just wanted to add, from the perspective of, I guess, individual organizations versus the larger group, I think it's going to be important for data sharing and data learning to be bi-directional, right? Everyone should be able to understand what are all the services that a particular client or patient are receiving, and then what's the score, let's say, of the success, that the person is stabilizing, that their diabetes is improving, that they're no longer, receiving physical therapy or ambulating well. Whatever that is, everyone should be able to understand that, and not just the hospital or the MCO from the claims perspective. Now, those might be the pathways to get the insights as to how someone's doing. But in the end, the CBOs have always been omitted from that knowledge, to be able to kind of come back and see how their services impacted a person's experience or successful health outcome. So I think if there's a way to make sure that happens, then that serves CBOs in much bigger ways, especially, CBOs that may not have big tech, but are able to see the impact of all of the amazing services they provide.
Thanks, Dorella.
I think related to that, this is Faven, is thinking about how the services and programs are evaluated. I think oftentimes healthcare systems have different metrics, evaluation metrics that they define for CBOs that, respond to reimbursements or what they get funded for. And sometimes CBOs are concerned about being over medicalized or being pulled away from their mission, or not being recognized for the unique work that they do that, isn't measured by a clinical measure, or, it extends beyond just one person being connected to a PCP, right? The work that goes into connecting with that person, the work that gets put into building relationship. I mean, some of these things are not valued by healthcare systems, and it's not taken into consideration when CBOs are being funded. And so I think from our experience, CBOs are often concerned about being pulled away from their mission and from the work that they do in order to be valued and financed by healthcare systems.
This is Sharon, and I think that, Faven, I think that's an interesting point. However, I would break it up into two parts. One is, I agree with you, and I believe that the medical system as a whole does not value community partners, which is why we are fighting for scraps all the time. And Shoshana, no disrespect intended towards you at all, but I started introducing myself to say, I don't understand why we're trying to create an integrated service delivery system and then the CBOs are separated from the medical providers. That does not bode well towards integration, in my estimation. So I feel like, on the one hand, to answer Faven's question, I think if we want to say as community providers that we have a reimbursable role as it relates to addressing social determinants of health towards improving health outcomes, then we have to frame those services, service delivery, and service impacts in the context of healthcare with a reimbursement stream attached to it. And for the more broad mission-driven work, that's why we have grant funding. But I think that if there are ways to create Medicaid reimbursable streams, like we're fighting for harm reduction Medicaid reimbursement, we're fighting for reimbursement for peer-delivered services, we're fighting for continued reimbursement for care coordination through health homes, right? So those are aspects of our work, and then we supplement them with grant funding. I also think that because the health system, and I just want to share one very brief experience that I had. I sat for 5 years on an executive committee governing board of a DSRIP. As DSRIP was winding down, it was a hospital-led DSRIP. They had an infusion of cash, and they were going to give 100% of it to the medical providers. And as one of the only CBO voices at the governing board table, I took a deep breath and I said, how is it possible after 5 years of DSRIP and integration that you don't see me as a CBO partner and you don't value me because I am not in your formula for distribution? And they said, oh, well, we're giving all the CBOs a little bit of money. If that's not the answer, in the end, I was able to negotiate 10% for the CBOs and 90% for the medical providers. That's what we're up against. So until we have until we are a required component of the delivery of medical care that is reimbursed, those medical providers are not going to partner with us in a meaningful way. Again, this is my personal opinion. I also think that the health information exchanges and Healthix, if it was required by Medicaid to have social determinants of health, we could get social determinants of health providers, community resource network providers, to have access to the HIE so that we could all see their contact, and now community health homes can see contact data so that it can help us with our case finding and linkage to care. So I think that there are ways that maybe we just expand the existing HIE to include social determinants of health elements within medical record tracking.
Thanks, Sharon, and no offense taken whatsoever. But I think the HIEs, especially Healthix, but all of them, even at the state level, have been working on trying to incorporate SDH data, CBO participation for years. And I won't say many, there are CBOs who do participate in the HIE in New York State. However, it still requires a ton of infrastructure, data capabilities, analytic capabilities, technical capabilities to parse the information, even if you're able to sort of receive alerts and access bi-directional, even unidirectionally. So I think a lot more, that's a great point, but it needs to it requires serious investment. And I know that there's a group at the state who's looking at other places like the Gravity Project to try to standardize and harmonize the data such that CBOs can participate and that even SDH information is in there. But those are all excellent points. And if you meant why is the CBO sector broken out this morning from the other two sectors, I think that's really interesting. And I love, I don't know, for Litsa, if you all discuss that, but it is a good question.
Yeah, I was speaking a little bit to that, but I think part of that is related to the symposium series. And so if you haven't joined every single session, then it makes sense it wouldn't necessarily connect in the same way, but we did integrated sessions in the first 2 parts of the series. And so this one was to try to get a little bit of a different perspective and be able to focus on kind of these topics, with the sector specific perspectives in mind, to try to really drill down, because I think as engaging as those other symposium series have been, obviously there's a lot of different competing like needs and discussions. So I think the purpose of this was to try to just bring in a different type of engagement.
I wanted to add a perspective. Sunnyside Community Services, along with JASA, Self-Help, and some other organizations, and the Department for the Aging, formed an MSO. It took years. And the success, which has just started in November, and we're seeing profits already, has been to be able to pinpoint the pain point of, in this case, Health First and their bottom line. They were seeing their patients not seeing their primary care physician and end up in the emergency room. They tasked us with getting them to their primary care physicians. And we broke it down and were able to identify all different benchmarks and milestones that, and you can really see the line to how this is going to help them have better outcomes, but also save money. And that is working. It's working for us and for them, but we had to be very specific in what we targeted to do with it.
And Jonah, did you, in forming that MSO, where's the locus of authority? Is it you each have governance roles on the MSO, or is there a separate entity?
So technically the entity was formed by Department for the Aging, which works out very well for us because we have one system, one set of negotiations. It's not every organization negotiating. How we resolve the problem looks different. So how we staff that can look very different depending on the communities. But what Health First sees is one portal, one connection.
I would also like to add that Carter Burden has been at the table with the inception of the MSO. It's been more than, it started back in 2015 as with the collaboration of DFTA and Aging in New York Fund, which is the nonprofit entity. It has taken many years to get to where we are today. But to Jonah's point, the outcome is the important component here, is that we had to learn to start to speak the same language. We had to also begin to see each other's value, particularly on the healthcare side. And as a result of that, we've been able to, one, be able to raise funds and receive revenue for the work that typically is undervalued or underpaid, depending. And we are making a difference as far as getting beneficiaries back to their PCPs or connecting them with additional social services that will impact their health outcomes. So it has been a very interesting journey. And I use the word journey because this did not happen overnight. But there are systems that were set up through this process that made it, I think, a little bit more doable. And I think for the CBOs, we pretty much speak the same language within that group. So it's a learning and sharing of how we do business, I think is another way of saying that.
Interesting. Jonah, there's a question for you in the chat. I don't know if you can see it, but Sharon.
Yeah, I can give a simple answer. The number one goal is they see their PCP, and these are folks that are most at risk. They might have gone a year, they're released from hospital and then go an entire year where nothing that Health First does can move the dial to get them to see their PCP. So what we do is we contact them, we figure out, are there other social determinants of health that we can handle, such as transportation, language, understanding their insurance, get them their appointment and get them to go to the doctor. So of course, there are a lot of milestones. They pay us for very specific milestones along the way, but the number one goal is get them to see their doctor.
Did you have a time frame for that?
May I also add to that? People who have been out of the healthcare system for the annual screenings now are actually scheduling those annual screenings, whether it's mammogram or colonoscopy, and we know bottom line preventative screenings lead to reduced health, health expenditures.
I
Interesting.
would just like to give a gentle reminder that we only have 8 more minutes left in this breakout session, just because
Okay.
I don't control it bringing us back. So we will be pulled back to the main
Okay.
room
So-
at 9:15.
Thanks, Lisa. So let's move on to key action number 3. That was a good discussion, though, and perhaps one of the more relevant ones for us. So for this one, we're supposed to think about what is our sector's current approach to engaging communities in our work. Previous sessions reveal the importance of engaging the intended beneficiaries of system reforms in the planning, design, implementation, and evaluation of those reforms, and that this engagement was essential to advancing health equity. So then we think about what is our 2 things. What is our sector's current approach to engaging communities, and how do we anticipate our sector contributing to the goal of including the intended beneficiaries of the community resource network in its planning, design, implementation, and evaluation? Faven, this gets to some of what you were asking before. Anyone want to handle this? It's what we do, right? Engaging community. So we're deep in.
I wanted to just, as we think about the healthcare system, each of the healthcare systems have community advisory boards. And those community advisory boards, there are representation from CBOs that sit on those advisory boards. I think that is truly another entree into the healthcare system. And it is helping to further establish engagement with the healthcare system. And I do think that it's important as we think about the CBO's role, again, to Sharon's point, you got to be at the table. You may not get any resources or funding initially, but you're there at the table, understanding the planning and what the future direction of that healthcare system is. And if you recall, all of the healthcare systems are required to do a 3-year community assessment. And being a part of that is also important as we think about the services that we deliver to the community.
Mm-hmm. What about with respect to the payers? Similarly, what are the points of entree for being at the table as the payers? People have talked about Health First, of course, but even some of the others. Has anybody had positive experience there, or thoughts about how we engage as CBO at the CBO level, and then also thinking about intended beneficiaries in those conversations? Okay.
Well, Shoshana, this is the water we swim in. We do this. We have consumer advisory boards. We incorporate client satisfaction surveys and consumer perspectives into our service delivery and design. It's at the medical provider level and at the payer level that they barely talk to us. And when we do talk to them, they don't listen. So I'm not sure what you're looking for. Other than to say, take a lesson from us. We can show you how to do this if you want to.
I think it would, our job is, this is a panel, again, just to remind you, being convened by Public Health Solutions. And our task is to share the CBO perspective on these questions. So bring it. That's Sharon's point, hopefully recorded and on the record. I think perhaps going one step farther and saying,
I'll never get another contract.
What would it look like for them to, I was trying to formulate the question, what does it look like for them to engage and incorporate CBO voices and get closer to community? And I think, we heard about how to do that with being on advisory boards on the hospital side. So I was just asking, is there any recommendation that the group wants to make to payers? If it's, we don't have a lot of time now. So I think the message is figure out how to have us join, the seat at the table. Okay, and then let's just, in the sake of, oh, we're extending to 9:53. Okay, we have a few more minutes. So is there anything anyone else wants to say about key action number 3 besides, you can vent, we can continue to just vent. It's
Shoshana, this is Dorea. I think I just want to add that it would be amazing if managed care organizations understood that everything is not contingent on a claim or the only diagnosis that's recorded when someone's admitted into the ED or into a full hospital admission. I think there is a challenge for an MCO to understand all of the support that a community-based organization provides, and that has value, monetary value to it. So if Medicare can understand that when someone's being discharged from the hospital, they need meals for 30 days and sometimes for longer. So how do you, make that happen? That there's clear understanding of the fact that, well, they're no longer hungry. Okay, but then they need all these other support. So how does that get discovered? And the MCO cannot do that. Someone else has to do that work. And I think there's a way to help MCOs kind of reinterpret the way that they're working. Like, there are organizations in California that are like Kaiser, they're looking at healthcare in a completely different way, and CBOs are at the front of that. So that's just the thing that I would push. Like, if the state is trying to break the mold and the model, then MCOs have to be willing to reinterpret what it could look like.
and I would add, not just,
ways, yeah.
Right, not just willing, but required, in fact.
Well, I also think that with, Medicaid managed care, working plan by plan is, as we've all said, incredibly time intensive, and it's hard for the providers to parse by insurance plan. So that means it has to happen at the state level because, frankly, Health First does more than a lot of the other plans does. And, we can, as many of you know, I worked there for many years, we can bash them, but they're doing a lot more than a lot of the other Medicaid managed care plans. And the other ones aren't going to do anything unless they're forced to. And so that policy issue is at the state level, much like the Medicare policy was at, the system-wide level, that they decided that this was a way to save money. It's always going to be saving money. I mean, let's be real. There's only so much in a premium. You can't say that they're going to, pay for everything that we would like them to pay for. It's going to be connected to medical costs. But that's my point, is that it's a state, doing it plan by plan is incredibly time consuming for us. I mean, we probably all have stories about spending personally, like, once every 2 weeks with certain plans for 3 years and still not really having a robust program. That's it. Sorry.
Yeah, I think also that linking this back to some of the points we discussed earlier about how to engage community, one thing that is really awful for providers and the attendant beneficiaries, patients they're serving, is to have plan-specific interventions. So if there were some way that we could have plan-agnostic programs so that a provider didn't need to parse, does this person have Health First? Does this person have Fidelis? Does this person have Metro Plus? Right? It's a terrible way to serve people. And so, that's just another point I want to throw in, without getting into sort of like collusion and antitrust. Like, is there a way to organize programs, social service, human service, that open it up so that it's, we're getting beyond that problem.
And Shoshana, I don't want to
Yep,
take over, but I know we have a minute left. I think we did speak to like the tech ecosystem and disjointedness and interoperability and all that. That's the last key action item. But are there any last thoughts on like what we're going to report back to the group on some takeaways that you want to ensure kind of,
Yes, can you actually advance the slide to number 4? I think we should just have quick.
Definitely.
run through of this slide. So this is about employing regulatory methods and advanced policy and practices that ensure a favorable technology ecosystem. We have talked about this. Do we have a speaker designated, Ralitza, a reporter?
I think that would be you if you feel comfortable. I can share with you the notes. We have some key takeaways.
Okay, that's fine. Anybody want to talk about this other, beyond what we've already said? I think a really important point is that the ecosystem can't just increase referrals without other streams of reimbursement.